Hi, this is Jessica Leone. I am hosting a webinar called the New York State Cancer Report and Response of Medical Providers and Staff. I work for the Primary Care Research Institute at the University at Buffalo, and this is funded by the Erie County Department of Health. The purpose of this webinar is that the community has greater concerns, understanding and learning about the community you serve to provide better care, improving the patient experience, and lastly, fostering better communication with patients for better outcomes. In this slide, we can see cancer incidence rates from 2012 to 2016. These incidence rates are broken down from United States on a national level all the way to just males in Erie County. So this is just touching on general cancer. It's not a specific cancer. And we can really see the increase from the United States all the way to Erie County itself. Today, we still see gaps between race and ethnicity when it comes to different health diseases. For example, I pulled these charts from the Center of Disease Control, and the graphs show new prostate cancers in the United States in 2016 on the left, and on the right, the graph shows new cases of prostate cancer specific to Erie County. We can see that in both of these graphs, African Americans have a higher rate of prostate cancer than any other race. I think it's just important to acknowledge that this gap still exists and is present in our community. Multiple factors contribute to African American health disparities. For example, we can think about social environments such as educational opportunities, or race or ethnic discrimination, neighborhood or workplace conditions, and or access to preventative healthcare services such as cancer screening. More specifically to Erie County, the New York State Health Department pulled data from 2011 to 2015 to determine if there were higher rates of cancer within specifically the east side of Buffalo and West Cheektowaga area. In this area, our community serves mostly African Americans. 70% are African American, and the other 30% accounts for the other races. Where compared to Erie County as a whole, these numbers are actually flipped. So the white race actually makes up 78% of the population. As well as 33% of the population lives below the poverty line. As for the study from the New York State Health Department, they launched this study in 2018 and released the report in 2019. The study area is shown here. Walden is the border along the bottom, the 90 borders to the right, and then the 33 borders the top and to the left as well. The health department launched this study to examine trends and risk factors in the different regions that had higher rates of cancer. Erie County was one of them, along with 3 other sites in New York State. So what did they look at? They gathered information from secondary sources, for example, the state's cancer registry, to pull socioeconomic, cancer, behavioral, healthcare, and occupational data. And lastly, they pulled environmental data to determine patterns and trends and contributing factors to the higher rates of cancer specific to this area. From these resources, they looked at different risk factors such as tobacco use, obesity, healthcare coverage and services, outdoor air pollution, radon, drinking water, industrial and hazardous waste, access to healthy foods, traffic patterns, and lastly, occupational exposures. There's a couple nuances to this data that they did not actually go into the community and they only looked at secondary sources. So what were the cancers that they found? So there were 6 different types of cancer that were higher in this area: oral, lung, prostate, esophageal, kidney, and colorectal. So what did the New York State report find? 5 of the 6 cancers were statistically significant, with one exception being oral cancer, where the numbers were small and the elevation was not different from what we would expect to see. Men ages 50 to 64 had statistically significantly higher than expected incidence rates of esophageal, lung, colorectal, prostate, and kidney cancer. Women overall had higher than expected incidence rates of kidney cancer. They concluded that high rates of tobacco use contributed to the elevated incidence of lung, oral, esophageal, kidney, and colorectal cancers in this area as well. Other factors contributing to the higher rates could be from industrial exposures. In this area, it was historically home for several industrial facilities. We could also think about access or knowledge about routine screenings that could have played a role in the increase of rates. Many of these cancers were diagnosed at distant stages, concluding a lack of access to healthcare possibly, or a lack of routine screening or monitoring, as well as access to healthy foods could have played a role as well. So when we're thinking about screening, we can think about provider barriers to screening itself. So competing demands for time, lack of awareness of screening recommendations or guidelines. I know there's a couple different guidelines and recommendations out there. Which ones do we actually go by? Limited time to discuss shared decisions with the patient themselves. And lastly, personal attitudes and beliefs about screening. So we want to also touch on the patient barriers to screening. There can be inadequate access to healthcare or availability of services, which are very important because I believe they saw this in the report, the New York State report themselves. Competition of survival priorities, so thinking about other people before themselves and putting family members before themselves. Do they need food for their family? Things like that. We also see mistrust of medical providers not going by what they're saying or their recommendations because they don't trust them. Lack of knowledge or awareness of preventative methods. We can think about culturally sensitive cancer approaches. And lastly, fear concerning medical treatments. And the best example I could think of is colonoscopies. A lot of people fear these and the process leading up to them, the procedure itself. So just a few things to think about from the provider side and the patient side. As for risk factors, we can really think of risk factors as a whole from the behavioral side, such as alcohol and smoking, which the New York State touched on as a contributing factor to higher rates of cancer within the East Side and West Cheektowaga area. But we can also think about that environmental piece. We know this area was high in or housed a lot of industrial sites in the past, and we can also think about the individual themselves, thinking about family history and using that as a preventative tool for our patients to use, and as well as guiding our recommendations for screening. So next I have a little skit that I will go over, and it's really just touching on the patient experience between a provider and a patient. First, I'll do a bad version of a patient-doctor interaction, and then I'll go right into the good version. So here we go. Dr. Jones, I'm here today because I've been losing weight. Losing weight is a good thing. You have hypertension and your cholesterol is a little elevated. But it seems that my stomach has been really queasy and I'm nauseous a lot to where I don't have any appetite. Well, try to eat some crackers or some toast and see how you feel. Doctor, don't you think I may need some lab work or some kind of test to see if I have something going on? Just try this first and come back in 2 weeks, and I can give you some medication for the nausea. Let's get your colonoscopy scheduled. You are due. Okay, I will try it even though I feel like something else is going on. Okay, I have another patient I have to see, so I will see you soon. So that was the bad version. I'm going to go right into the good one now. Good morning, Mrs. Raglan. How are you doing? Is there anything you would like to address today? Dr. Jones, my stomach is really queasy and has been up for over a month now. I have no appetite as well as I have been losing weight. Mrs. Raglan, even though losing weight is a plus in a lot of situations, this is not normal for you. We will get some blood work ordered before you leave. Have you eaten today? I've been really nauseated, so I've not eaten yet. Has something else happened recently to bring this on? Well, Dr. Jones, my son in Michigan has recently been diagnosed with lung cancer, and I'm so concerned about him. I'm so sorry to hear that about your son. That must have been very stressful. Do you have anyone you can talk to about this, such as a pastor or a counselor? Thank you. I do attend church regularly and find guidance through praying and talking with my pastor. That's great. Continue to use your social supports when you need help and let me know if you need any referrals to anyone else. I also see from your history that you have H. pylori from a nervous stomach some years back. Let's get that lab work done and go from there. I'm not going to prescribe anything today, but I would like to monitor your appetite and journal the foods that you eat when you get nauseous. Have some crackers and ginger ale in the morning or hot cereal in small amounts. No fried food. Thank you, Dr. Jones. Lastly, since cancer runs in your family, I would like to get some blood work for this. You are also due for your colonoscopy. Let's get this scheduled. I agree. Since my son has been diagnosed with lung cancer, I feel I should be proactive about screening. I hope your son is doing well, and we will figure out what is going on with your weight after you get the blood work back. Let's focus on you. Is there anything else you would like to address today? No, thank you, doctor. I will see you soon. So before moving on to patient-provider strategies that we can use to improve outcomes, I want to just discuss a little bit about the skits. So we could see in the first skit that the doctor wasn't very sympathetic to the patient and just kind of ignored that something else was kind of going on. And he also touched on her having a colonoscopy, but since the provider didn't really show that personal touch or that sympathetic touch, that patient is probably not going to abide by that recommendation. And then in the second skit, the good skit, we could see that the doctor was more sympathetic. He was open to hearing the patient out on what was going on in her life that could have caused her to have this nausea. And he really showed interest in her, as well as when bringing up the colonoscopy, the patient was more responsive to that, saying, oh, you're right, like my son has lung cancer, so I probably should be proactive about screening recommendations. And the doctor also just touched on looking back in her chart to see what else was going on in her past and just giving her recommendations, and also touching on that social support system that she has as well to go through this process. So next, we're just going to talk a little bit about strategies that we can use to improve that patient-provider communication. So next up is patient-centered communication. We can really start by focusing on what the patient needs and values and wishes, allowing the patient to voice the concerns, and finally, just provide empathy and validation of concerns. So we can really start by building rapport by having positive conversations before diving into that health medical agenda items. So asking about the weather or just generalities about the day, really just focusing on those non-specific, encouraging observations that will help with building rapport with that patient. Avoid asking, how are you doing or how are you feeling? These questions tend to lead to the patient describing more physical symptoms and concerns. And then we can start by asking, what can I do for you today? Or what can I help you with today? Or is there anything you were concerned about today to bring focus to the reason for that specific visit? Next, we can prioritize with the patient different health concerns by asking what one they would like to address today. And then finally confirming the issue or concern with that patient. And then after addressing their health concerns, you can start to address your personal concerns for that patient, which may have not been brought up or talked about yet in that visit. By addressing their needs and concerns first, this builds a trusting relationship as well as shows compassion and empathy for that individual, concluding the visit with confirmation of health goals and possibly commitment of abiding by that medical treatment that you were talking about. There are 3 goals in this patient-centered communication, and they are 1, understanding the patient perspective, 2, understanding the psychosocial context, and then reaching a shared treatment goal. Next is Ask Me 3. We can really use this to establish health literacy between the patient and the provider. So just concluding the visit with these 3 questions: what is my main problem? What can I do? What do I need to do? And why is it important to do this? Can it increase the health literacy of the patient and the understanding of the medical appointment by just providing a brief summary of what was talked about. So next up is Say Ah. It's a really great resource focusing more so on health literacy. And they also have a really great website for providers and patients, and just gives a bunch of resources within little tabs, so go check that out. So Say Ah really focuses on what the patient needs to know and not what is nice to know. And we should be putting the most important information first by prioritizing, and then after addressing, it's so important that you understand and know this, and then repeating if necessary. So tips to communicate clearly: we want to limit the information to 3 to 5 concepts. Use everyday plain language. We want to define medical terms. We want to really be positive and empathetic to that patient's experiences. And then link motivations to life. So for example, we can say this medication will help you walk up the stairs or help you be more present in your family life. We can also work with office staff to make sure forms are easy to read or font size is big enough, or directions on pamphlets or sheets of paper are understandable. And we can all participate in creating an environment that benefits the patient when it comes to health literacy. And lastly, I just want to touch on the Teach Back method. So it's just a way for the provider to address how the provider explained concepts within that visit. So it asks the patient to explain in their own words what they need to do or what they know so far. And once the patient does this, we review any points that the patient missed and then ask the patient to re-explain the concepts back. So it's not a quiz or a test for the patient. It really just checks for understanding, and it's a chance to re-explain if you missed any points within the visit. So here is an appointment planning worksheet that we created for this specific project, and it really just goes through how to talk to your doctor about cancer prevention. And if you're interested in having this in your practice, please just reach out to me and I can send you some copies as well. So it just goes through things to bring to your appointment, picture ID, just some specifics on that left-hand side. And in the middle, there's some services or resources that can be utilized for the patient, such as the Cancer Services Program through Erie County, where they provide free cancer screenings for mammograms, breast exams, and colorectal exams. And then there's the website on there with the phone number. We also just included 211, which is a great resource if you don't know about it. It's a 24-hour hotline where you can call 211 and ask for any specific resource within the community. They also have a website that you can search on as well. So this is just a cool resource, and then I'll go through the inside. So on the inside, we can see cancer risk factors. Like I said, I touched on the family history portion within this presentation, but just reiterating how important it is to know your family history. And then that environmental piece, that your environment plays a role in your risk for cancer, and having the patient list some of their risk factors in their life. In the middle is some cancer screening guidelines, so just going through colorectal screenings, lung screenings, prostate screenings, stuff like that. And then on the right hand side, just their screening plans. So, when was their last screening? When will their next screening date be? And lastly, just going through those Ask Me Three questions, just to reiterate the importance of that visit and what they need to do after the visit's over. So, some key takeaway messages, just starting with a positive attitude can really change the visit and the visit outcomes. Next, engaging the patient as active participants in their own care. So, having that patient be an advocate for their own health and having say in their own medical treatment, or giving that patient options of what they could do to participate in their care. And lastly, just acknowledging the community barriers that surround your patient's daily life. We all live in different environments and surroundings, and it's just important to acknowledge that we all come from different backgrounds, and that plays a role in how we abide by our medical treatment plan or your recommendations that you give that patient. So, just really keeping that in mind when interacting with anyone you come in contact with. And finally, here is our contact information. Again, I'm Jessica Leone. You can email me with any questions, concerns, comments. I would love to hear back from anyone. And I hope you enjoyed this presentation. So, thank you. Bye-bye.